Hello, everyone. Thank you so much for your attention. My name is Peter Jangalewski, or Dr. DZ, as most people abbreviate my last name. I'm the Chief of Head and Neck Surgical Oncology and Microvascular Reconstructive Surgery at the University of Florida. And in this presentation, we're going to do a little overview of our team and what we do at UF. So the core team of us includes three surgeons, including one of my partners, Dr. Conrad, who, like myself, did a lot of his training in Canada. And then he did our fellowship here at UF and trained with myself. And he's an expert in head and neck cancer ablation, reconstructive surgery, robotic surgery, basically the full gamut of what we do. Next, we have Dr. Austin Lamb, who joined us a year ago, and he initially trained in Washington State and then did a fellowship in New York City at Mount Sinai. And he as well has the full armamentarium of head and neck surgery skills that we all need to practice a full practice of head and neck cancer surgery. Myself, I've now been at UF for 12 years. And during that time, we've really built a big, strong head and neck program with a fellowship as well as research programs. And we're continuously trying to push boundaries of what we're able to do for our patients. There's just some examples of us here at work and working together as we often do. We also collaborate with a lot of other specialties. A couple that I wanted to highlight would be oral surgery and prosthodontics. So we work with Dr. Hardiman and Dr. Davla, and our goals with these collaborations are to provide patients with full oral reconstructions, including teeth and other oral appliances. We have a few programs that I'll highlight here. One is our trans surgery program, where we use this mainly for oropharyngeal cancers. And we do that to maximize functional outcomes, minimize long-term toxicity, and give patients a good option as an alternative to more traditional means of chemo and radiation. We also have our own Florida dental augmentation rehabilitation technique where we reconstruct mouths with teeth. We also look at a lot of functional outcomes in oral cancer and kind of combine clinical care with research. We see a lot of advanced skin cancer here in Florida, and we'll show some of that as well. And then we also have an advanced endocrine practice where we don't see a lot of very straightforward thyroid and parathyroid cases. We do a lot of very complicated ones that are sent to us from other centers that can't tackle them. So for transrobotic surgery, what is this exactly? Well, we're using a robot to operate in the mouth, and we control that robot with a joystick that's away from the patient. And our goal here is to de-escalate therapy, especially in HPV positive oropharyngeal cancers. Right now, what we have is the latest robot called the single port system, where there's a single cannula that a lot of the instruments go through. And so this picture here on the A side is what we used to do with all these different arms going in the mouth. Now we just have one access point, and that allows us to get to a lot of tumors in the back of the tongue and in the larynx that we couldn't get through before. Here's just a little example of what that looks like. I'm just going to, it just skips right here to the actual cancer cutting portion. And you can see these are our robotic arms. This is kind of our older arms. The newer technique looks very similar to this, but essentially what you're seeing is what we see on a screen, except that we have a three-dimensional visualizer. So this all is viewed in 3 dimensions. And that sort of goes on. I'll just fast forward here kind of towards the end, just to give you an idea what that looks like. And we have our own papers that we published, our own experience on this, especially for earlier cancers where patients have outstanding survival rates using this. In cases where surgery itself is used alone, we have a 90 to 95% 5-year survival. It's the same if post-op RT is added in cases that need it. We've stopped using chemo post-operatively for these patients, so we're able to de-escalate them that way, and we don't give them a maximum dose of radiation post-op if they need it. We stop at 50 or 60 gray, and they have excellent quality of life outcomes. We also use this a lot for carcinoma unknown primary. So where patients come in with a neck mass that has cancer and we don't know where it started from, we can detect where the cancer started from using this technique in over 70% of cases. In fact, it's probably closer to 85% these days with the newer robot. And by doing this, if we can resect the cancer, they're usually very small. We can often limit the amount of radiation patient needs or completely omit it. And there's some examples of where that's being done, where the primary site is being omitted with the use of robotic surgery. So we can really de-escalate these patients because, as you know, the more radiation we give them, the more time over the quality or of the course of their life they have to diminish their quality of life. As each year they live, the worse these side effects get. And we've shown this since 2013. These studies have continued to come out showing that these minimally invasive approaches to tonsil invasive tongue cancers have excellent quality of life outcomes. Patients' speech and swallowing outcomes come back to a very close to near baseline level after they've recovered from radiation if they need radiation. So de-escalation has really started over the last probably about 15 years or so. One of the first major studies was done here at UF in collaboration with UNC, where we looked at using radiation with chemotherapy at 60 gray instead of 70 gray, and that's now become our standard. We hardly ever give 70 gray unless it's a heavy smoker with a P16 negative cancer. For P16 positive, we usually give 60 as our standard. We also have a clinical trial where we've gone down to 50. There are other clinical trials around the country where they've gone to 36. We're typically staying in the 50 to 60 gray range. And in the postoperative setting, it's closer to 50 with no chemo. And if you look at swallowing and speech outcome scores and quality of life data, you'll see that what this chart's trying to show here is that the less treatment you give, the better the patient's outcomes are. So in the TORS only, for example, the lower the score in these graphs, the better the outcome. So the TORS numbers are the lowest here, where you look at the patient's swallowing scores, and you can see that with surgery, only the patients have the best swallowing outcomes. As you start adding radiation, as each year goes by, those scores get worse and worse, whereas for swallowing, it basically stabilizes after about a year and stays that way. So as I mentioned, in this case, we're trying to go with less as being more, trying to minimize approaches to low dose of radiation or just surgery if possible. And this tends to be a great option for smaller cancers of the tonsil, lateralized base of tongue. And there are certain indications that will exclude. If we have to do a huge resection that requires reconstruction, we'll usually avoid it in these cases, because in those cases, patients will often be better off with a low dose of radiation and no surgery. Some other examples from that we've published is we've shown using this mode in our experience, we've had a very high survival rate with no recurrences in our data set. And there's been no difference in survival between surgery only and surgery with radiation treatment. So we still can't say in patients that have indications for radiation that they should omit it, but we're seeing in patients who decide that they don't want radiation, because we will recommend it if needed, but there are patients who will forego it, and we've seen a lot of really good results in those patients. So the future really is de-escalation. It's really becoming the standard in most places. Giving 70 gray with chemo and radiation is unlikely to be the standard in the future. It's already changing that way in academic centers. And the question of should we include chemo or not is also coming up a lot. There are studies to show that it doesn't offer a lot of benefit, even in patients who have classic indications for adjuvant chemo and radiation, for example, in patients with extranodal extension. There's examples of cohort studies of thousands of patients where giving chemo made no difference. And so some places are not giving it as much anymore, even if there are indications for it. And we certainly avoid giving it in the postoperative setting in these patients. Other things that we've started doing, this was sort of the future. It's kind of the now. We've been doing this for the last 3 years using NavDX. It's a circulating tumor DNA test. It looks for HPV DNA in the bloodstream, and it has a negative predictive value of about 100% and a positive predictive value of 94%. And initial studies were done between UF and UNC with this as well. And we're thinking that this can eventually be used to de-escalate treatment. And we can definitely use it to monitor for recurrence. What we know so far from these tests is that if it's positive, the patient has disease. Whether you can detect it or not, it will become detectable at some point. So if we use it postoperatively or post-treatment and comes back positive, that tells us there's a recurrence brewing if we don't know where it is. So we can definitely say that. If it's negative postoperatively, it seems to be about 94, 96% accurate that the patient is disease-free. However, we still don't have the data to tell us, okay, postoperatively it's a negative test, but the pathology has indications for radiation. Can we tell the patient you don't need radiation? We can't. We still don't have that data. However, we do have a lot of patients who, when we tell them it's zero and we say we do recommend radiation, they say, I don't want it. I'm not going to do it. And they end up doing close observation. And we have a large cohort of these patients so far where we've only had a couple of patients recur, and it's usually months or a year or more later, and they have been salvageable. So we don't know the answer yet, but it sort of looks like many of these patients maybe don't even need radiation. And then the ones that do recur are still salvageable. So it may be a risk worth taking, but we just don't have that data yet. But this is kind of the exciting part of where our specialty is going. So just some examples. How can we use HPV DNA here? So here's an example of a patient with an advanced base of tongue cancer. It's the big ones in the middle. Surgery would be very debilitating for this patient. So it's really not a great option. We're going to go with radiation here. And we would plan to give the patient 60 gray with chemotherapy once weekly. And so the pre-treatment DNA test would show us, let's say, 10 to the fourth copies of DNA. At 50 gray, and this is kind of how our clinical trial is working, 50 gray, the patient has 0 copies. So in our clinical trial, we can stop at 50 gray in this case. This is what we're hoping will become part of the future. This is what we're studying right now. This isn't exactly yet mainstream, but this is kind of what we're looking at. Another example, we have kind of an intermediate stage tonsil cancer. We decide to do robotic surgery with a neck dissection. Pre-treatment DNA, 10 to the fourth copies. Pathology does have some indications for radiation treatment. And what we see here is at least 3 indications. So normally we would say the patient needs post-operation therapy. However, 1 month after surgery, there's 0 copies of the DNA in the patient's bloodstream. The test is negative. So now what? Well, do we observe? Do we do radiation? How much? Well, Emory is currently looking at a protocol in this case where they would give 36 gray post-operatively. Again, this is a clinical trial, so we're not using this off trial, but it's an idea of how this might be used. We would normally recommend post-op RT in this case, and it would be a discussion between the patient and the radiation oncologist, somewhere between 50 and 60 gray with no chemo. And as I mentioned, some patients do elect to just observe in this case. We tell them it's risky. We don't have this answer yet. Maybe in the future, this will be the way we go. Essentially, we're basically trying to create a multidisciplinary collaboration to minimize long-term dysfunction and maximize their survival. All right, so moving on. So another exciting area that we're very proud of is our virtual surgical planning techniques that we use to rebuild patients' mouths after a major oral cavity cancer surgery. And our goals here are to fully reconstruct and rehabilitate the oral cavity after surgery and radiation. It was once good enough to just take out the cancer, slap some piece of flesh on there, close the hole, and be done with it. We're much more advanced than that now. So here's an example of a patient who had a tumor, a cancer in their maxillary sinus. The red portion of the picture here shows the area we need to resect. And so we're planning this preoperative using 3D imaging and designing how we're going to resect it and then how we're going to reconstruct it. So here we're using a portion of the patient's fibula to reconstruct the missing bone. And then we're planning dental implants to go in it as well so we can give the patient teeth. Here's an example where we're going to take the bone from the fibula, and then we can print the 3D patient-specific cut guide that fits right on the fibula, and it has cylinders for where the implants are going to go, and we can place that right on the patient's leg. This is just another view of how we're planning where the implants are going to go in the bone. And this is what it looks like in vivo in the patient's leg. So we've got the flap being perfused by its vessels in the leg, and we put the cut guide on in the leg, we put the dental implants in, and it's kind of difficult to appreciate, but this is the view here. It's hard to get the 3D image, but this is kind of a side view of the patient's maxilla being reconstructed. You can see the dental implants, 1, 2, 3 sitting there. This is what it looks like at the end of the case. The patient's all closed up there. And then this is a couple of years later, what he looks like. It took him about 6 months to get his teeth. And then here's 2 years later. And here's another example of a patient 4 years later with a similar situation where we've completely reconstructed their mouth. And they tend to do very well. And that's sort of one of our older techniques of reconstructing the mouth. We've now become even more advanced, and I'll show some of that as well. We tend to get a lot of very advanced cancers. This is an example of a patient who was treated for a sinus infection for many, many months. And eventually she went to an oral surgeon who said, something doesn't look right here. Your teeth shouldn't be so loose. And she had this massive adenoid cystic carcinoma of her midface. And so this is the area that we need to resect. And then we use her fibula to reconstruct the midface. It's a huge, huge defect. You can see her face is very swollen here. When you look in her mouth, the teeth are just really floating in this huge tumor. There's another view of it from underneath. You can really appreciate how big it is. And so we have to really open up her face, remove her entire palate and midface. That's what it looks like from the inside top-down view here. This is, again, tough to appreciate in 2 dimensions, but in 3D, you'd see there's really nothing left of her upper jaw. And this is us reconstructing it using the fibula. And then this is what she looks like on the table. And this is her as she's leaving the hospital, day 7. And then this is her a few months later as she's recovered from her surgery. And so these are some of our older techniques of things we were able to do, and now we're really trying to push our boundaries. Here's another patient with very, very similar cancer, similar reconstruction. We were able to get him teeth. And as many of you probably know, getting teeth is not cheap. Insurance usually doesn't cover it. It's very expensive. But with our dental school, sometimes we're able to 3D print teeth for patients, or we have some ways to get them some pro bono work. And this was a gentleman we were able to do that for, and we gave him a dental appliance that functioned very well for him. Some other techniques we developed are a variety of different tongue reconstructions using templated based designs of flaps. This is an example of a patient where we had to cut out half their tongue, part of their pharynx, and we used their forearm to rebuild it. And this is a really template specific design. Here's another example of how we do this. So we try to be very methodical and as scientific as possible. And this is an example of what one of these looks like long term. This is a patient about 4 years out. She's now close to 7 years out from surgery. And you can see that after surgery and radiation therapy, her tongue still moves well. She's able to eat and drink everything she wants. This is an example of a patient who also had a similar type of surgery. And you can see here, there's her tongue, sticking it out, moving it left and right in all directions. Her speech is essentially 98% normal on speech intelligibility tests, and she eats a completely normal diet. She's now 8 years out from surgery. So these techniques have survived the test of time. And, as I mentioned before, we do see a lot of advanced cancers. This is an example of one of them. This is a gentleman who had a massive cancer, had his entire mouth essentially. So we had to cut out his entire tongue. And, in some countries around the world, they consider this to be a surgery that they won't do because the outcomes are so poor that essentially a patient like this is terminal. We feel that that's, a discussion to be had with the patient, but in many of these patients, we can actually reconstruct this very well. So unless you're used to looking at surgical videos, I'll take you through this. On the left side of the screen, we have the tumor, the entire tongue. On the right here with the yellow, we're looking up into the mouth. The yellow is the inferior border of the mandible. And then the forceps down the bottom are holding what's left of the tongue, which is basically a strip of tissue attached to the larynx right there. And so here we can take a patient's thigh, some of the skin, the fascia, the fat, and the muscle, and use that to rebuild a new tongue. We basically try to put as much tissue in the mouth as possible, knowing it's going to shrink over time. And that's kind of what it looks like after about 3 years. And if we do a scan afterwards, we can see this. We've completely reconstructed a scan. And if the patient is dedicated enough and willing to do the rehabilitation, they're able to eat and drink in about 50% of cases, completely without a feeding tube. The other 50% use the feeding tube and are still able to eat and drink by mouth. But many of them just aren't as dedicated to the therapy to get to that point. But it is possible for them to eat and drink everything by mouth. And you can understand about 60 to 70% of what they say if they do the rehabilitation. So they can still have a very reasonable quality of life. And so overall, for these variety of techniques that we're using to reconstruct tongues, we have an excellent G-tube rate at 1 year, very good sentence intelligibility, and most of them will return to a baseline quality of life at about 1 year. And this is where our boundaries are being pushed now. This is sort of the latest techniques that we're developing and how to optimize patients' full reconstruction. We call this a jaw in a day. And I'll illustrate this with an example. This is a 15-year-old girl who had an aggressive benign tumor of the jaw. And it was an inflammatory myoblastic tumor that's known to potentially spread, grow through structures, but it's not technically a cancer. So we had to remove a good portion of her mandible. And we planned to reconstruct it with dental implants. But we wanted to take this one step further and get her teeth at the end of the case. So she would leave the OR teeth. So here's our exposure to the mandible. And what you can see is this is our patient-specific cut guide that we put on the mandible. You can see kind of the whitish areas are bone. This red, dark areas here is tumor. These are some of her teeth that are just kind of floating in this tumor. So we cut out the cancer. There it is. And then in her leg, just as mentioned before, we put the cut guide on. We put the dental implants on in the leg. There they are. We have this reconstruction bar that holds everything together. And then we can put a dental prosthetic on these as well. And that'll go on in the mouth. So we are here attaching the fibula, the neo jaw, into the old jaw. And then at the end of the case, she leaves the OR with teeth. There you go, fully reconstructed mouth. And then so what she looks like about a month afterwards. Teeth are there. And then she'll get a final dental prosthetic that's going to look even better than this one eventually. And here's her about 4 months later. And now she has her final prosthetic, and she's about a year out and doing very well from the surgery. So that's where we're looking to take things. Other areas that we see a lot of cancers are skin cancers. Being in Florida, we tend to see a lot of skin cancers. We tend to see the really big ones in our clinic. And so there are going to be things like this, very neglected skin cancers, patients who don't have a lot of social support or a lot of access to medical care, and they tend to come out with these massive cancers that end up in big defects like this, where we have to take big pieces of flesh to reconstruct them, and essentially it just becomes like a pancake of tissue on the side of their head. And here's another example. Scalp cancer is very common here in Florida. Same idea. Take a big piece of flesh. This one was using muscle from the back, the latissimus, and skin grafts over top of that to reconstruct this. But we now have a new tool in our toolbox, and this is immunotherapy. Just a couple of years ago in 2022, there was a study published in the New England Journal of Medicine looking at these advanced stage cutaneous squamous cell carcinomas and using cemiplimab, or Libtayo is the trade name for it, as immunotherapy on these cancers. And since then, a lot of people have been using this all over the world. And this is kind of the way it works. It doesn't always work. We still don't know who it's going to work for, who it's not going to work for. We don't have a perfect playbook for this yet, but there are many instances where it makes sense to use this. So, for example, this is a gentleman who had a scalp cancer right on the vertex, and it was invading his sagittal sinus. So it was not resectable. If we took him to surgery, we would either give him a positive margin or he would die from the surgery. So this is a great option for trying cemiplimab. So we got his first dose and it looked worse. Very common. A lot of the time, these cancers will look worse after 1 or 2 doses. So you can see here on the far left is baseline. It got worse after 1 dose. After 2 doses, it's something in between. And then it starts to get better. After 4 doses, 5 and 6 doses, almost undetectable cancer. And on his latest scan, there is no detectable cancer. He's had 8 doses. And so in some of these cases, we don't know when do we stop the cemiplimab. Usually we do it for about a year and then see what happens after that. Sometimes, if there's any possible disease left, we might give a small dose of radiation, then a much smaller dose than we normally would. And in some cases, if there's still a small amount of disease left, we'll resect it. And if there's no disease in the specimen, they may not even need radiation therapy. So this is great when it works. Now, there are cases where it does the opposite. You give 3 or 4 doses and it gets worse. In that case, you're forced to go to surgery and radiation or just radiation. But this is definitely an up and coming treatment. We don't have all the answers yet. But we are using it more and more. This is an example of a case where it may not be the best option since this is a huge lip cancer. Even if it shrinks it down, he's still going to have a huge defect that's going to need to be reconstructed. So in a case like this, it doesn't always make sense to use it. And so here we would do the surgery. And this is a big resection, part of the mandible, lips, chin, and then we reconstruct this. In his case, 2 flaps. We use a fibula to reconstruct the mandible, and then a forearm to reconstruct the chin. But as time goes on, these may also become less and less common. Who knows? Using more and more of the cemiplimab, we may see that even in cases like this, it makes sense to use it up front. And we are starting a clinical trial to look at that. Endocrine cancers, benign, non-benign tumors. We get a lot of these, a lot of revision cases for parathyroid tumors, cancer, mediastinal tumors, like an example of this one here. They tend to come to us. The easy ones tend to go to much smaller places, but we are very, well versed in more complicated cases, big, massive goiters. There seems to be an epidemic of these in Florida for some reason, and we see a lot of these. And so we were very well versed in dealing with these massive benign and cancerous tumors. All right, so that's what our program looks like. Some things on the horizon. We're in the middle of hiring a 4th head and neck surgeon. The 3 of us are already very, very busy, and we're looking to hire a 4th one to kind of complete our team. We are looking at opening a multidisciplinary clinic and potentially some outreach clinics as well around the state. We're looking at combining our clinical programs and research together in our new multidisciplinary clinic. And as I mentioned before, we're working on some immunotherapy trials. We have one that's opening soon. And those are kind of the big things that are coming up on the horizon at our UF Head and Neck Surgical Oncology program. And that is it. If you have any questions, please feel free to reach out to Karen or myself, and I'll be happy to help you out. Thank you very much. Take care.